Ever get that feeling?
Yeah.
You're staring at just like a huge amount of medical
Oh,
info.
yeah, like trying to find a needle in a haystack.
Exactly, like sifting through sand, trying to find the important bits. Well, today on the deep dive, we're sort of grabbing that shovel for you.
Hmm.
We're digging into myelofibrosis. And the mission, really, is to pull out the absolute key stuff you need. Maybe you're just trying to get your head around it, or maybe you're revising hard for something like the MSRA.
Right. We've got these notes, and we're going to make them work for you.
We want this to be your go-to guide, basically.
Exactly. Think of it like a streamlined plan for understanding myelofibrosis. We're not just, listing facts. We're breaking down the really core ideas.
What it is, why it happens.
Yeah, how you spot it, what the management strategies are. We'll cover the definition, the causes, the risk factors, right through to treatment, and, well, the potential problems.
Okay, sounds good. Let's jump right in then. What actually is myelofibrosis?
Okay, so myelofibrosis, or MF for short, it's a rare chronic condition. It affects the bone marrow.
A blood cell factory.
Right. And the key problem is that the marrow, which should be soft and spongy, it gradually gets replaced by this tough fibrous tissue, like scar tissue.
Okay.
And that scarring messes up the normal production of blood cells. Its class as a myeloproliferative neoplasm basically means an overgrowth of those blood-forming cells.
And you mentioned primary versus secondary.
Yes. It can start all by itself. That's primary myelofibrosis, PMF. Or sometimes it develops out of another blood disorder someone already has, like polycythaemia vera or essential thrombocythemia. That's secondary MF.
Got it.
And you also get something called myeloid metaplasia. When the main factory, the bone marrow, struggles, body tries to compensate, it sets up like backup factories in places like the liver and spleen.
Right, so the production moves elsewhere.
Exactly. The diagnosis relies on criteria from the World Health Organization, the 2008 ones, and sometimes you might hear it called agnogenic myeloid metaplasia. Same thing.
Okay, myelo for marrow, fibrosis for scarring, marrow scarring disease. That makes sense. Like that dried up sponge idea can't do its job.
That's a good way to think about it.
So what actually triggers this scarring? What's the etiology?
Well, for primary MF, the exact cause isn't known. It's kind of idiopathic in that sense.
Okay.
But, and this is really key, there's a very strong link with specific genetic mutations, things like JK2, CALR, or MPL genes.
Ah, the genetic connection.
Yes. These genes normally help regulate blood cell production, but with these mutations, it's like the on switch gets stuck.
Constantly signaling to make more cells.
Precisely. It drives that uncontrolled proliferation that eventually leads to the fibrosis. And understanding this, especially the JK2 pathway, has been huge for developing treatments, like JK inhibitors. We'll definitely talk more about those.
Right. For secondary MF.
That comes from those pre-existing conditions. The polycythaemia vera, or essential thrombocythemia. It's the abnormal stem cell activity in those conditions that ultimately triggers the fibrosis.
Okay, so no single starting gun we know of for primary, but these genetic factors are crucial drivers. Are there things that make someone more likely to get it? The risk factors.
Yeah, there are several. Age is a big one. It's much more common in older people.
Okay.
Exposure to certain chemicals, maybe some toxins has been suggested. Also, having had radiation therapy or chemotherapy before.
Right, previous treatments.
And definitely having another myeloproliferative neoplasm already puts you at higher risk for secondary MF. Demographically, it seems more common in white individuals and also in Ashkenazi Jews.
Interesting.
And there's a slight tendency towards men overall, but interestingly, in young kids, it seems to affect girls more often.
Huh. That is unexpected. Okay, so we know what it is, who might be more at risk. Let's get into the mechanism. How does it actually work in the body? The pathophysiology.
It really comes down to those abnormal stem cells. For reasons we're still figuring out, they start churning out excessive amounts of fibrous tissue right there in the bone marrow.
The scar tissue buildup.
Exactly. And this fibrous tissue physically pushes out, replaces the normal, healthy blood-producing cells.
So the factory floor gets taken over.
Right. And the result is disrupted production of, well, everything. Red cells, white cells, platelets.
Which leads to?
Typically anemia, not enough red cells, so you feel tired, weak. Thrombocytopenia, low platelets, causing bruising or bleeding. And often you see abnormal numbers or types of white blood cells, too.
So the factory's not just clogged. The actual workers are getting evicted by this fibrosis.
That's a really good way to put it. The whole production line is compromised.
Okay, that paints a clear picture. Now, if someone comes in with symptoms suggesting this, How do you know it's definitely myelofibrosis and not something else that looks similar? What are the differentials?
That's a really crucial point because symptoms like fatigue or an enlarged splenomegaly, they aren't unique to MF. You absolutely have to consider other myeloproliferative neoplasms, PV, ET, CML.
Hmm.
Also, other things can cause bone marrow fibrosis, like metastatic cancer that spread to the bone or even certain infections.
Okay, so cancer spread is a possibility.
Yes. And then you've got myelodysplastic syndromes, chronic myelomonocytic leukemia, even acute myeloid leukemia can sometimes present in ways that overlap.
So quite a few possibilities.
Definitely. So if you have that patient fatigue, big spleen, you need to rule out a whole list of things through careful testing before landing on myelofibrosis.
A thorough process of elimination, then. Let's talk numbers. How common is this, especially here in the UK? What's the epidemiology like?
It's definitely considered rare in the UK. Getting exact figures is always a bit tricky with rare diseases, but
Roughly.
the annual incidence, so new cases per year, is estimated around 0.4 per 100,000 people.
Okay, not many.
No. And the prevalence of the total number living with it is thought to be somewhere between 4 and 6 per 100,000.
So fairly small numbers overall.
Very much so. The median age at diagnosis is around 60. Most people, over 90%, are diagnosed after 40, but like we said, it can happen at any age.
That few grains of sand on a large beach idea seems fitting.
It does, yeah. It helps put the rarity into perspective.
All right. So when it does occur, how does it typically show up? What are the clinical features? What should you look out for?
Well, it can be quite variable. Early on, some people might have, no symptoms at all. It might be picked up on a routine blood test.
Okay.
But as it progresses, symptoms usually start appearing. Fatigue and weakness are very common, often from the anemia. Unintentional weight loss, too.
Right.
An enlarged splenomegaly is a classic sign. That can cause abdominal discomfort or a feeling of fullness. Bone pain can happen, night sweats, itching, which can be quite troublesome, and easy bruising or bleeding due to low platelets.
That's quite a list.
It is, and the blood counts often reflect this. Anemia is common, thrombocythaemia too, although sometimes platelets can be high initially. White cell count can be high, low, or normal, but often shows immature forms.
Is there a handy way to remember those main symptoms?
There is, actually. A useful mnemonic is FWEB9.
FWEB9.
Yeah, fatigue, weight loss, enlarged spleen, bone pain, night sweats, itching, and bleeding.
Okay, FWEB9. That's helpful.
And in more advanced disease, you can get really significant constitutional symptoms, just feeling generally unwell, major weight loss, those drenching night sweats, maybe a low-grade fever.
And the spleen.
The splenomegaly can become massive, really huge, which causes its own problems. Pain, feeling full really quickly after eating, risk of splenic infarction where part of it dies off, portal hypertension, even pushing up on the lungs, causing shortness of breath.
Wow.
Yeah. And the anemia causes fatigue, weakness, breathlessness. Low platelets can lead to anything from tiny red spots, petechiae, to serious GI bleeds.
So what might a doctor find on examination?
Well, the enlarged spleen is often palpable, sometimes hugely so. Maybe an enlarged liver, hepatomegaly, paleness from anemia, those petechiae or bruises. Signs of low white cells, like maybe oral thrush if neutropenia is present. Sometimes swollen lymph nodes, signs of portal hypertension, even gout.
Okay, FWEB covers the main symptoms, but the clinical picture can be quite broad. When MF is suspected, what investigations get ordered?
Investigations are absolutely key, both for confirming the diagnosis and figuring out the stage or severity. Blood tests are the first step.
Full blood count.
Definitely. Looking at red cells, white cells, platelets. But also looking for those specific genetic mutations, JAK2, CALR, MPL.
Genetic markers.
Crucial, but the gold standard, the definitive test, is a bone marrow biopsy.
Right, looking directly at the marrow.
Exactly. Take a small sample, look at it under the microscope. That lets you see the degree of fibrosis. It's graded usually 0 to 4, and look for abnormal cells.
And imaging.
Imaging like ultrasound or MRI can be useful too, mostly to check the size of the spleen and liver, and sometimes to see signs of fibrosis in those organs as well, that extramedullary haematopoiesis.
Okay. You mentioned diagnostic criteria earlier, those WHO ones. How do these tests fit in?
They fit right in. The 2008 WHO criteria require a combination of findings. There are major criteria, or A criteria, and minor, or B criteria.
Okay.
Generally, you need to meet all the major criteria plus at least 2 minor ones. The major ones involve the bone marrow biopsy showing significant fibrosis, usually grade 3 or more, and having one of those mutations like JAK2 or MPL. Or, if no mutation, then ruling out other causes like CML or reactive fibrosis.
And the minor, the B criteria.
Those are more clinical and lab findings. Things like a probable spleen, unexplained anemia, seeing immature cells in the blood, that's leukoerythroblastosis.
That sign of marrow stress.
Exactly. Also, finding teardrop-shaped red cells on the blood film, having those constitutional symptoms like night sweats or weight loss, and histological evidence of blood cell formation outside the marrow.
So it's a real combination: marrow appearance, genetics, blood picture, clinical signs. What about the more detailed molecular tests?
Very important. Cytogenetics, looking at the chromosomes in the cells, helps rule out CML and finds other abnormalities present in about half of MF patients.
Oh.
Testing for that specific JAK2 V617F mutation is vital, found in maybe 45–68% of primary MF, and you absolutely must check for the BCR-ABL1 gene to exclude CML.
Right, exclude the mimics.
Precisely. And tests for PDG-FRA, PDG-FRB rearrangements can be relevant, especially if there's a high eosinophil count. And always remember, MF can overlap with or develop from other MPNs like PV or ET, and it carries a risk of transforming into acute myeloid leukemia, AML.
So a really comprehensive workup is needed. Bloods, marrow, imaging, detailed genetics. Once you have that confirmed diagnosis, what's the approach to management?
Management is really about a few key goals: controlling symptoms, maintaining or improving quality of life, and managing complications.
Okay.
And it's vital to state upfront, the only potentially curative treatment currently available is an allogeneic stem cell transplant, SCT.
The only cure.
The only potential cure, yes. But it's a very intensive treatment, and not everyone is suitable. Factors like age, overall health, other conditions play a big role.
So for many people, it's not about cure.
For many, it's about supportive care, managing the specific problems they have, like the anemia or the big spleen. It's often palliative in intent. And sometimes, if the disease isn't causing many problems and the risk score is low, just observing, watchful waiting might be the initial strategy.
What about medications? Are there drugs that help?
Oh, yes. Medications play a big role in symptom control. Hydroxyurea, sometimes called hydroxycarbamide, is commonly used. It can help shrink the spleen, lower high white counts, lower high platelet counts.
Okay.
And more recently, the JAK inhibitors, like ruxolitinib, have been a major advance.
The drugs targeting that faulty pathway.
Exactly. They can be very effective at reducing spleen size, improving those difficult symptoms like fatigue and night sweats, and there's evidence they might improve survival for some patients.
What else for managing the spleen specifically?
Besides hydroxycarbamide and JAK inhibitors, other options might include thalidomide, prednisolone, lenalidomide. And in really difficult cases where the spleen is causing major issues, surgery to remove its splenectomy is sometimes considered, or even radiation to shrink it.
And the anemia?
Managing anemia often involves red blood cell transfusions when needed. Sometimes drugs like erythropoietin, which stimulate red cell production, can help.
And you mentioned myelosuppressive therapy.
Yeah, that's typically hydroxycarbamide used primarily to control high cell counts, the leukocytosis or thrombocytosis.
Let's go back to the stem cell transplant, the allo-HSCT. What makes someone eligible?
Right, so allo-HSCT aims to replace the faulty marrow with healthy donor stem cells. It offers that chance of long-term remission or cure. There are different intensities: fully myeloablative, which is very strong chemoradiation, or reduced intensity, which is less toxic and better for older or less fit patients.
And eligibility.
It depends heavily on age, the patient's IPSS risk score, which we'll talk about specific chromosome abnormalities, their overall health, and importantly, having a suitable donor. After the transplant, sometimes donor lymphocyte infusions are used to help maintain remission.
What if the disease progresses to that blast phase, BPMF?
That's a very serious situation, essentially becoming acute myeloid leukemia. The prognosis is generally poor. Options are limited, but might include intensive chemo, trying to get to an allo-SCT if possible. As acididine is sometimes used palliatively, supportive care is always critical.
So management really spans from observation to highly intensive treatments depending on the situation. What about the long-term outlook, the prognosis?
It's quite variable. It really depends on the individual, their age, general health, the specific genetics of their disease. Some people live with stable disease for years.
while others progress faster.
Yes, or transform to AML. And again, allo-SCT is the only curative option. Doctors use scoring systems to estimate prognosis and guide treatment. The main one is the IPSS, International Prognostic Scoring System.
IPSS, what does that look at?
It factors in age, hemoglobin level, white blood cell count, the percentage of blasts, immature cells in the blood, and whether those constitutional symptoms are present.
And that gives a risk score.
Exactly. It categorizes patients into low, intermediate 1, intermediate 2, or high-risk groups, each with a different estimated median survival. There's also a dynamic IPSS, which adds a few more factors for potentially better prediction during the course of the disease.
What factors increase the risk of transforming to leukemia?
A high white blood cell count and certain specific abnormal karyotypes or chromosome patterns are known to increase that risk. So those factors used in the IPSS age, blood counts, blasts, symptoms, are key for assessing prognosis.
That IPSS sounds incredibly important for planning. Finally, what sort of complications can arise from myelofibrosis?
There can be quite a few, unfortunately. Anemia is almost universal and often needs managing. Increased risk of infections is common because white cell function can be abnormal even if counts are high.
And bleeding.
Yes, bleeding disorders due to low or dysfunctional platelets. Portal hypertension is a big one, stemming from the enlarged spleen and altered blood flow through the liver. That can lead to variceal bleeding, ascites, even hepatic encephalopathy.
Serious issues.
Definitely. Transformation to AML is a major complication. There's also a slightly increased risk of other secondary cancers. Splenic infarction, that loss of blood supply causes acute pain, might need hospital treatment, possibly even splenectomy or radiation if severe or recurrent.
What about bones and immunity?
Bone complications like joint pain or osteosclerosis, a hardening of the bone, can occur. Immune system abnormalities can lead to autoantibodies, amyloidosis, or increased susceptibility to infection.
And that blood production outside the marrow.
Extramedullary haematopoiesis, yeah. That can cause problems depending on where it happens: organ enlargement, bleeding, compression of structures. Radiation is sometimes used to control specific sites. And finally, due to high cell turnover, uric acid levels can go up, leading to gout or kidney stones.
It really does sound like a domino effect, starting in the marrow
Yeah.
and potentially affecting so many other systems.
That's a good way to think about it.
Wow. Okay, that's been a really thorough journey through myelofibrosis, from the definition, the causes, the signs, diagnosis, management, prognosis, and all those potential complications. It's clearly complex,
It is.
but hopefully this deep dive has helped structure it and make it clearer, especially if you're trying to revise this for the MSRA or just understand it better.
Absolutely. Key takeaways: chronic marrow disorder, fibrosis is key. JK2CPL, RMPL mutations are common drivers. Splenomegaly and fatigue are hallmark symptoms. And allo-SCT is the only potential cure right now.
Great summary. And if you do want to cement this knowledge, particularly for the MSRA, we
Okay.
really do recommend checking out pastthemsra.com.
And freemsra.com as well. Both are excellent resources for preparation.
Definitely worth a look. It really makes you think, doesn't it? The complexity of these chronic conditions and how much progress is still being made in figuring them out and finding better treatments.
It certainly does. Continuous learning and discovery.